So thank you, Rashmi. Thank you for all the energy you develop to improve the research and the management of the disease in many patients. Normally, you should see my screen. Is that okay?
Yeah, we see your screen.
Perfect. Actually, I'm an adult physician, but I won't speak only about adults because now we are all convinced that SGA and AOSD are the same disease. So really, we move to the direction to say we speak about still disease, and what we will discuss now is the main guidelines for all patients, children or adults. So this is something very important. And thank you for Dr. Kana to have presented all this basic information in order for me just to focus on the management of the disease, on the clinical aspects and the treatment. So either in children or in adults, we have these four pillars with the fever. So recurrent fever, very high fever, frequently it's every evening for more than 1 week, 2 weeks. So very difficult situation for the patient and for the parents when it's children. The rashes are very important. The first description was a salmon pink rash, so something very subtle. Now all lesions corresponding to urticaria are also included. Normally, it's only focused on trunk and limbs, not on the face, for example. So, but the rash is a very important symptom to make the diagnosis. The joint symptoms are also very important. So, sorry. Scott, can I explain to you that arthritis is not mandatory, and we really want to emphasize that just arthralgia is enough to speak about joint involvement. And if you have to wait for arthritis, you will lose time and you will reduce the efficacy, the chance for the treatment to be fully efficacious. In some cases, the joint involvement may lead to erosion, so joint dislocation, let's say, and this we were used to say that it's approximately 1/3 of the patient who will develop this erosive disease, joint disease. But actually, we have the feeling that nowadays, since we treat the patient more rapidly, the percentage of patients with erosive disease is probably not so high, which is the good news. And finally, the fourth pillar is the increased CRP and the increased neutrophil count. So it means that you have a lot of inflammation in this patient. Besides that, you have many other manifestations that have been described. Scott Canard discussed about the cardiac involvement, pericarditis, myocarditis, pleuritis, liver, so liver function test increase. You have also life-threatening complication, fulminant hepatitis, macrophage activation syndrome. So the situation may be very um, um, reassuring at the very beginning, but it may evolve in the wrong direction. So for any physician, when you make this diagnosis, you have to be very careful about the possibility of some very complex complication. There is also an heterogeneity in terms of evolution. So there was this discrepancy, or this separation between the children form, so HGIA, and adult form, but it's completely arbitrary related to the organization of the care. Systemic features are really very important to speak about celiac disease, but some patients will have specific organ involvement or macrophage activation syndrome. And for some patients, there may be a chronic articular evolution. However, in adults, we have the same, as I told you before, the feeling that when you treat the patient very rapidly, you will avoid this chronic joint involvement. So it's something very important. And there is also an evolution heterogeneity. Some patients will have just one flare of the disease. We can't say the patient are cured because a relapse is always possible, but some patients will have only one flare during their life. We don't know why, but it may happen. The majority of the patients will have recurrent flares after a few months, after a few years, and we have no clue, no marker to identify which patient will do a relapse, which patient will remain in remission. And for some patients, we have a progressive disease with a very limited control of the disease, so something which is more chronic. Once again, we don't have very strong data, but the idea behind our recommendation, especially, I will explain that to you in a few minutes, is that the earlier the treatment and probably the lower the risk of chronic evolution. And just to, I don't want to go into much detail in terms of pathogenesis of the disease, but we have the feeling that there is two steps in the disease. For some patients, you just have the four pillars, the still disease manifestation. And for these people, for this patient, we will say it's an autoinflammatory disease, meaning that it's a disbalance or a dysregulation of the innate immunity, this part of the immune system which is in charge of the first defense against infection of this kind of thing. And here there is a very important role for IL-1 and IL-18. In some patients, there is development of macrophage activation syndrome, perhaps also lung disease, perhaps also other organ involvement. And for this patient, we have this notion of hyperinflammatory disease, which means that you have the involvement of the innate immunity and also of the adaptive immunity. The adaptive immunity is the one which is so with lymphocyte, for example, in charge of reacting against a specific aggression or infection, and so you developed a very specific response to this aggression. And here, IL-18 is still important, but interferon gamma is also a key player. So this is important just to recall very simplistic way of explaining the disease, but it's a way to see what are our mode of action in terms of treatment. So as I told you, there were some recommendations. It was in 2023, where adult physician and pediatric rheumatologist worked together to identify a few main messages to help physicians to manage a patient with such a disease. So so in this type of recommendation, we have what we call overarching principles. So really big and strong ideas, very general. And besides that, specific recommendation. So in terms of overarching principle, we have decided to say that SGIA and AOSD is the same disease. So now we would be very happy to use the unique name of still disease for all these patients. So of course, you have some differences between children and adults, and children, very young children, are probably more at risk of developing the disease compared to older children, but it may happen also in adolescents or young adults. And macrophage activation syndrome, for example, is more frequent in very young children. We did two other overarching principles. The second one was the notion of shared decision making, really to include, to involve the patient and the family of the patient into our decision, our understanding of the disease, and what could be the way of managing the disease. And another very important point is to say that we have to adjust the treatment depending on the disease activity. So it's not just a one standard treatment, and which will fit for every patient. You have a global strategy, but it has to be adapted depending on the evolution of the disease and the different marker of the disease. And the ultimate goal for still disease is to achieve a drug-free remission. So we have in mind that it's feasible to reach a drug-free remission. It's not cure because there is a risk of relapse, but still, it's if we have the optimal management of the disease, probably we will increase the percentage of people for which we will be able to stop the treatment after a few months or a few years. In terms of diagnosis, we recall here the four pillars. And so this is a very practical recommendation, but to say that arthritis is not absolutely needed. So, and it's the idea behind it is not to lose time waiting for arthritis. And here we identified two very important biomarkers, CRP, as you know, and ferritin. And ferritin is not fully specific of still disease, but compared to many other inflammatory diseases, ferritin, still disease is the one where ferritin is the highest. And ferritin is very closely related to IL-18. So it reinforces the link between still disease IL-18, and ferritin. For when we have a patient in front of us, we have to identify the target we want to reach with the treatment. So here we were not fully we use in daily practice some composite indices where we combine the patient global assessment or the parent global assessment, the number of joints involved, the level of CRP, the level of ferritin, if you have some different symptoms of the disease. So here we don't have a unique tool for children or adults. Probably we'll have one in a few months or years. But what we decided to say is what we want to achieve is a clinical inactive disease. So it's a way for us, all the physicians, to have the same vocabulary to manage the disease. And the clinical inactive disease means that you have no still symptoms and that you have no inflammation, no CRP, no elevated CRP or ESR. And remission is the same, the clinical inactive disease, but for a certain period of time. And remission, you can speak of remission after 6 months. It can be remission on treatment or remission off treatment if you're able to taper the treatment and to stop it at the end. And very importantly, it was not the way we produce a recommendation for every disease, but in still disease, it's a very challenging disease, very active disease at the very beginning. So we identify intermediate targets. Clinically inactive disease may need 6, 12 weeks to be achieved. And we need before to be sure that we're going in the right direction. So we identified at day 7 that we want to have no fever and to have a substantial decrease of CRP. At week 4, no fever, reduction in joint symptoms, normal CRP, and the physician and parent patient global assessment need to be below 20 on a 0 to 100 VAS. At month 3, we want a clinical inactive disease with a low dose glucocorticoids. And at month 6, the clinical inactive disease, but we don't want glucocorticoid anymore. Because one of the problems, and we'll come back to that in a few minutes, glucocorticoids on a long term have many side effects, and we don't want to expose children or adults to glucocorticoids for a very long period of time. This is very important nowadays. In terms of treatment, so here you see in this recommendation that we started the recommendation by to avoid prolonged systemic glucocorticoid use. If you use glucocorticoid, you will be able to control the disease, but you will have side effects. So this is why we recommend to use IL-1 or IL-6 inhibitors, and they have to be prioritized because we have a very high level of evidence to say they are efficacious in this disease. And we added another recommendation to say that this treatment has to be initiated as early as possible. It means that it's not only for people who are refractory to glucocorticoid. It's as soon as you make the diagnosis, it's really recommended to start this targeted therapy if they are available in your country, because it's a way to reduce the exposure to glucocorticoid, and it's a way to control more depth the disease activity. And here, this is what we have in the literature, in the scientific literature. It's 2 studies. One is with anakinra, an IL-1 blocker. The other one is with tocilizumab, an IL-6 blocker. You see here that in terms of clinical inactive disease, if the treatment by anakinra is started in the first 3 months of the disease, you have 92% of clinical inactive disease. If it's later, it's only or approximately 40%. And here with tocilizumab, 54% if you treat the patient very rapidly, and none in this study of the patient achieve clinical inactive disease when the tocilizumab was used later. So very important message: don't wait for glucocorticoid side effect to start these treatments. And to simplify the thing, we did a decision tree where you have the disease, you look at the level of disease activity. If the disease activity is very high, high dose glucocorticoid will be needed. But as soon as the diagnosis is confirmed, then you can go with IL-1 or IL-6 inhibitors. If the disease activity is milder, there is a possibility to only use IL-1 or IL-6 inhibitors and to use lower dose of glucocorticoid, or for some patients, no glucocorticoid. Then we want to achieve the clinical inactivity, inactive disease with low dose glucocorticoid. If it's okay, it's perfect. You taper the glucocorticoid and you maintain the IL-1 or IL-6 blocker. If it's not achieved, then you have to rotate between IL-1 or IL-6 blocker, and then you control 3 months later to see where you are. Sorry. If the evolution is not in the right direction, you tested an IL-1 blocker, you test an IL-6 blocker, the response is not perfect, then you have to contact. In Europe, we have European Reference Network, and we have Reference Center for Rare Disease. In the US, it's not exactly the same name, it's the same principle. And the important thing is, if you see that the evolution is not as good as expected, you have to contact the very expert of the disease to be sure that you don't miss something, that maybe you have to adjust the treatment to add something to the IL-1 or IL-6 blocker. So very important to go to the very expert of the disease. And if it go on the right direction, you achieve clinical inactive disease and you're able to stop glucocorticoid after 6 months, then you continue IL-1 or IL-6 blockers for 3 to 6 months. Then you try to taper progressively the biologic agent up to the complete discontinuation. Of course, each time, if there is a problem, you have to be reachable for physician. We really explain to the physician, the patient have to know how to contact you, and in order, in case of flare, to reach you and for you to react to their symptoms. So a few words about complication. We spoke about macrophage activation syndrome. There is also this notion of lung disease, and Scott Canna explained to you what was this very new and surprising situation. And actually, we had a lot of information during the last 5 years, and now we have a clearer view of what can be done for this patient. And especially after the first description by our colleague in Philadelphia and Cincinnati, there was a European experience with a pediatrician from Italy, Germany, and the Netherlands. And what you can see here is the description of 50 patients with this lung involvement. What you see here, these patients were not new patients. It was patients with a chronic persisting disease. So something children, in this case, with quite refractory disease. A substantial number of them already had a history of mass, so it means that it was patient with very active and severe disease. Here, some of the patients, the majority, but not all, were exposed to anakinra or canakinumab or tocilizumab, so to targeted therapy. There was a question here to see, is there a role of the treatment in the start of the lung disease? And especially there was a question about hypersensitivity reaction to this treatment. Now we know that it's not the case, and you see that lung disease may happen without exposure to this treatment. And the other important thing, you had question about genetic marker. For these people with lung disease, our colleague identified that there is a specific, actually, allele, the DRBTA115. This is our genetic code that differentiates individual. And when you do a transplantation, you have to take into account this allele in order to have a good success of the transplantation. And here you see that people with lung disease have a very high percentage, very high frequency of HLA-DR-beta 115, between 70 and 100%. Or in the general population, it's only 25%. So at the end, what we say in the recommendation is that for people with lung disease, and it's potentially also the case for other organ involvement, it's not a contraindication to IL-1 or IL-6 blocker, But there is also an indication to start another treatment in addition to the IL-1 or IL-6 blocker to control the disease and especially to control the role of T cells in the mechanism of this complication. And final recommendation to insist on the fact that there are all over the world still disease expert centers, and for the physician, they have to be in contact with this center in case of any problem in the management of the patient. And my conclusion will be that, so thanks to the different treatment, IL-1, IL-6 blockers, there are major advances in the management of the disease. We think that thanks to this treatment and their earlier use, we are able to achieve clinical inactive disease in a large majority of the patient. Now we have new agents, especially biologic agent targeting at the same time IL-1 and IL-18. So potentially it can be really more efficacious than only blocking IL-1. There is also a new biologic targeting interferon gamma, which is something probably very important in macrophage activation syndrome. We have also already existing therapies that can be repositioned, such as JAK inhibitor. These treatments are blocking IL-6 and interferon, notably interferon gamma. So there are possibilities to use this treatment in future studies. And actually, there is a joint effort and several protocols, several trials building nowadays. And in each case, we have discussion between adult rheumatologists and pediatricians to find the optimal design in the study and to be as the most efficacious in the development of the trial and the achievement of the trial. So this is what I want to conclude on, and I will just thank you all the people who participated to the recommendation and to share with you what I have in front of me because it's spring in Paris.
That's beautiful. Thank you so much. So we can move on to a panel part of the event where we will have both the speakers who can take your questions. And oh, sorry, no, first the questions for Dr. Fautrel. So, like, if we have any questions, let me go through that. Luciana or Hani, feel free to um, read out any questions. Let me just. I think there was a question about tocilizumab, if that is the last option for medication.
No, it's not the last option. Um, as you saw, we put anakinra, so IL-1 blockers, and tocilizumab, IL-6 blocker, at the same level. We have the feeling that maybe IL-1 blocker are more specific of still disease, but tocilizumab also work. If you don't achieve the target you want with tocilizumab, there are potential additional option to test. And especially this is where, but it's not labeled treatment for which there is an approval, but there is some possibility even for patients who have an inadequate response to tocilizumab. So in our mind, it's not the last option, but if tocilizumab is not efficient enough, then you have to contact the expert center to discuss and to find the optimal option for the optimal solution for a patient.
Got it. I saw this question earlier, which was about it was about, I think, somebody's kid who got diagnosed. How long does the treatment last? Does it come under control? And I think this is question about controlled remission is interesting to address.
So as you saw in the decision tree that I presented, what we want, you want to achieve the clinical inactive disease. If then you want to taper and stop the glucocorticoids, then you maintain the IL-1 or IL-6 blocker, and you will try to taper and to stop. So we don't have for some patients, there is a flare. We don't know why some patients have a flare. Maybe it's the nature of the disease. Maybe it's because they have an infection, for example, or a new trigger that will provoke the relapse. So it's always very difficult. But what we don't have in mind that if you treat the patient for years, at some point there will be a loss of efficacy of the treatment.
Got it.
Okay.
Actually, on a related note, somebody has a question that I've been using anakinra since late 2002. Are there any other patients who've been treated long term with this medication?
We have patients who have been treated for years by anakinra or by tocilizumab. You have to know that these treatments have been developed for rheumatoid arthritis, and rheumatoid arthritis is the disease where the treatment are really on a long-standing perspective. It's 4 years. And we know that the side effect of this treatment are not related to the duration of the treatment. And very frequently, the side effects are more at the beginning of the treatment than after several years. So it means that we try to taper the treatment, and if possible, we will stop them. If it's not possible, we are not anxious about some side effects that may appear after 5 or 10 years. This is not what we have observed in rheumatoid arthritis patients. So this is why of course, we are very careful and concerned. We take care of we are very vigilant on that, but we don't have this signal from other diseases where the treatment are really chronic.
Okay, thank you so much. So we'll move on to the panel portion, which really does mean that you can address questions to Dr. Kenna as well, or we'll just raise it and whoever wants to answer can. We are also very excited to have Dr. Michael Jordan here, who has joined us, and he's here. So if there are any questions about bone marrow transplantation and in SJIS stills, you can ask those as well, and he is an expert in that area. So with that, let me just
Hey,
uh,
can I ask you a quick question? Do we have just a couple of moments for me to talk about the registry?
yeah,
Before,
let's do that at the end of the panel.
oh,
Uh,
gotcha. All right,
yeah,
yeah, I understand. Yeah.
let's do the panel questions first, and then we'll do that at the end of the panel. One question I'm seeing is there any connection found between Stills and Cushing's? Um, don't know if anyone wants to take that on.
Sure, I can jump in. Not in terms of the causes, but I think we frequently refer to someone who has a lot of long-term steroid side effects as having a Cushingoid syndrome or a Cushingoid appearance. Um, and Cushing syndrome really has a lot to do with overabundance of glucocorticoids in particular, and so uh, we tend to induce Cushing syndrome with long-term use of steroids in patients who unfortunately really seem to need them. But I'm not aware of anything on the front end.
Got it.
The same for adults. It's really something which is related to glucocorticoid exposure, and this is why we really we are fighting with our colleague to say there are other options like glucocorticoid for this patient. So you have to use glucocorticoid for a while, but don't stay on high dose glucocorticoids. And there is in the chat a question about BMTs in adults. Actually, it's absolutely exceptional in adults. And probably because the disease is, um, we have a lot of treatment. And I don't know. Besides that, I don't know. Maybe some of the children have some genetic predispositions that make the disease more intense, but it's very exceptional in adults.
I will just, if I could add a comment to that, it was pretty exceptional in pediatric patients too, till about I think 4 or 5 years ago, and then we saw like kind of the patients, one or two patients go in, and then more. So I don't know if Dr. Jordan wants to comment on that.
Yeah. So as a pediatrician, I don't have any direct experience with adult bone marrow transplant. I mean, I agree that it's extremely rare thing in adults. But I agree with Rashmi's point that yeah, we will see, right? So, but I think that in children certainly it's becoming, increasing much more common.
There's a question for, I think this is for Dr. Fautrel. It's an adult patient on Actimera for SJIA. Right now, the fevers and lungs controlled, but my joints have been really bad, and I'm in a wheelchair due to contractures. Other biologics controlled my joints better, but then nothing for my systemic symptoms, which is why we changed. Are there better ones for joints and systemic, or do people go on multiple?
Mm, There are people, some of my colleagues, especially in France, are likely to say that for joint symptoms, IL-6 blockers, so tocilizumab, there is another one, which name is sarilumab, may be more efficacious. It's not really my feeling. And actually, for whatever the expression of the disease, systemic or joint centered, let's say, I have the feeling that IL-1 or IL-6 blocker works approximately the same. In some patients with really chronic arthritis, we tested TNF blockers, but it's really a few patients, and I don't think it's something which is really relevant. So I can't, of course, answer directly to your situation, but I don't have the feeling that there is a more specificity of one treatment for joint symptoms compared to other one.
Someone is asking that their son's labs, in terms of the IL-18s, IL-2, CXCL9 is all normal. Everything else except for the platelets are still very high in the 500, 600. Does that mean that there's still inflammation somewhere in his body? He's been on steroids for 3 years straight now, on Jakafi steroids and tacrolimus.
I can handle that one. I mean, I think, if all that other stuff, the CXL9s and IL-18s and CRPs and ferritins are all normal, it might just be that this is someone whose platelet count runs a little bit high. And we've certainly seen patients who have been on mostly JAK inhibitors who, kind of as a benign side effect, their platelets have been running a little higher. So I don't know that in isolation I would be so worried about that platelet count being a little bit on the high side. It can be what we call an acute phase reactant, but almost always in the context of some of those other maybe more sensitive things being up.
Another question I see is about eosinophilia and stills, which is something that we see come up. Is the rash an itchy rash or a non-itchy rash? What to make of the kind of the high eosinophilia, the itchy rash, versus stills, which can often be the non-itchy rash? Or
It can be really tough, and I think that we've talked about the sort of classic Stills rash as sort of this red or salmon pink thing that comes with fevers. But you're absolutely right that in some children, especially those who seem to have a more challenging or refractory systemic course, they can have like this sort of chronic, very itchy rash that is associated with eosinophils in the blood, and seems to, at least from my vantage, be part of their primary disease. I don't want to speculate too much about why that might be happening or what it's going along with, but it seems, in my experience, to be a correlate of someone with, kind of smoldering systemic disease, and the rash itself can be really itchy and disruptive, and also as a sort of marker of the overall stills not being under great control, it can be a little concerning. Steroids work great for that, but obviously we've talked about how steroids are not a great long-term solution. And different places have dabbled with different sort of itchy rash directed therapies, whether it's topical things or even systemic medicines that might be used for people with bad eczema. We have a little bit of experience with that, but it's certainly not a well-worn sort of path for what we do in those situations.
If I may add something on that, I'm not clear about eosinophilia in Still's disease. And since the description of lung disease, we have the feeling that it may correspond to something specific. So nowadays, when we have an increase in eosinophils, we are looking for the HLA-D beta 115, and we are concerned about the possibility of an organ involvement, a lung disease, a liver disease, which can correspond to a subset or more active or more refractory disease. So I don't have the conclusion, but for me, it's just a warning that I have to go a little bit beyond and to check some other markers that could indicate that the treatment by L1 or acid blocker couldn't be enough, and then that additional, for example, immunosuppressant agents are needed.
Another question is, are there any upcoming clinical trials for new promising therapies?
Yes, there are with monoclonal antibody targeting interferon gamma, so it's more for macrophage activation syndrome. And in a few months, probably, there will be one trial with a bispecific monoclonal antibody targeting at the same time IL-1 and IL-18. And this trial, it will be completely new, will be accessible for children and adult patients. So it's a really, and it will be a way to achieve more rapidly the number of patients to be recruited to reach a conclusion. So these are the two main trials that are in the process to be developed.
Got it. There is an interesting question about a BMT patient. Maybe Dr. Jordan can take a look at that. They did BMT 2 years ago, and she lost all the donor cells 3 months later, but she's been doing great. And her monocytes and neutrophils are around 5%. Her T cells around coming down. And if you have any thoughts about that.
Yeah. And actually, there was another question a bit earlier in the chat asking about autologous versus
Yeah.
allogeneic transplant, I think. But in fact, those two questions, the reason I say that is because there's something kind of similar here. So if somebody has a transplant and they lose the donor cells, let's say completely, in this case, it's not really complete, it's a bit of a mix, then that's kind of the same thing as having an autologous transplant. In other words, you get the really high dose sort of treatment that's the chemotherapy and so forth that suppresses the immune system, and then you get your own cells back, right? And your own cells grow back, but you sort of have done a total reset on the immune system. So, an auto transplant auto transplants have been reported for severe SGIA in the past. There are not a lot that have been done, and there's not, I would say, a lot of excitement about doing them so much. Because the concern is that if you're transplanting children, especially young children, that there may be still some genetic component that we don't understand, and the disease may come back because of that. But having said that, what's been reported previously is that there are patients that will have sustained sort of remissions. And so the question specifically is that the questioner's daughter is apparently doing well despite having lost most of the graft. I would say that we don't know whether the residual bits of donor cells, in this case donor T cells, are basically to be credited, right, with making things better, or it was actually the act of sort of turning off the immune system and sort of starting over with transplant, which is what you also get when you get your own cells back. So it's hard to say exactly, what that means in terms of disease development, but also, which of these two possibilities actually are the reason for why her daughter is doing better.
Okay. Thank you. Scott, do you have any thought? Do either of you have any thoughts about that? About what it says about the nature of SGIA stills?
Nope. I agree with Dr. Jordan entirely, who is a lot more adept at a transplanter than I.
There is one more question about the correlation between successful therapies and patients that are positive for the HLA allele. Do some therapies work better than the others?
No, I think that when you have this allele, you respond correctly to the treatment, but you are at risk of some complication of the disease. So it's not a question of wrong or adequate or inadequate response. It's more about warning for us, physician, to be more careful on the follow-up of the patient. So it's more in that term that I would. We have some patients with this specific allele who are doing perfectly well. They respond only to IL-1 blocker, and that's it. But we consider it's a warning for us, and we have to stay careful on during the whole follow-up.
Got it.
I think it's a really tough question. I think our experience mirrors that of Dr. Fautrel's, where the patients who have this marker seem to have maybe a bit of more refractory course, but the person who's looked at this most closely, again, is Bas Vostert in Utrecht in the Netherlands, and their data suggests that the presence of that sort of genetic risk marker was not actually a risk marker, and the patients who had it seemed to do just as well as those who didn't. So I think that it may differ based on your geography or your other ethnic background, but it's still something that we're kind of wrapping our heads around.
You have to be aware. Sorry, you have to be aware. It's just for everybody to realize that it's we just identified that 5 years ago, and so we are still learning on the exact meaning of this marker. So it's really we at this stage, for me, it's more warning to be very very careful on the management of these patients, but maybe in 5 years we'll have more information to be more precise in how to use this biomarker.
I have a follow-up question for that, for actually Dr. Jordan. I've always meant to ask, given this HLA allele, does it make sense when you're choosing a bone marrow transplantation donor to make sure they don't have the HLA-DRB, that allele?
Well, it's actually it's a really different consideration. So in the context of transplantation, you actually want to match the HLA alleles, because when you have mismatches, that increases the risk of, say, rejecting the bone marrow or the bone marrow trying to reject the patient. So there aren't any honestly any examples of where, let's say you have a risk an HLA risk allele for a disease. It doesn't matter, whatever the disease may be, that we would actually want to mismatch the HLA of the donor and the patient if we had a choice. Now, oftentimes we have to do a mismatch because you don't really have an option. But if you have the option, you actually always want to match the HLA for reasons that have to do with sort of the complications of the transplant itself. The one thing I would say in terms of genetics is that if you have a disease disorder that's driven by a single gene, and you're looking at family members as donors, and you have you would want to obviously not choose somebody that has the same genetic risk that the patient, him or herself, had. That would be the only sort of thing. But that's when you have a disease that's driven by a single gene and not something like a HLA allele, right? We all have human leukocyte antigens. Just the question that some of this put us at more risk for one disorder or another. Right, so you'll have it. It's a question of whether or not it's a match between the donor and the recipient.
Okay, thank you.
And don't forget that 25 to 30% of the general population has this allele. And still disease is a very rare disease, maybe between one case for 100,000 people or 1 million adults. So it's a frequent allele. And in a very specific context of cell disease, maybe it can be associated with some manifestation. But you have a majority of people with this allele that have absolutely no immunological problems.
Well, thank you so much. Sorry, go ahead.
I was just going to say that just demonstrates. So this is not my area, so I wasn't going to speak to it, but that point actually demonstrates that it's a relatively weak risk allele, right? And that sort of risk associated with that HLA is just completely dwarfed by the risks of having a mismatch in the context of transplantation.
Got it. Well, thank you so much. I think we've addressed a bunch of the questions that have been posted here.